hypercholesterolemia, or also known as familial hypercholesterolemia, and their baseline LDL, which is supposed to be high, but if it's more than or equal to 190 milligrams per deciliter, this is a little bit too high. So I know for a fact that I'm going to put them on a high intensity statin, okay? And my high intensity statins are atorvastatin 40 to 80 milligrams and rosuvastatin 20 to 40 milligrams. So I could choose anything. Now, as I'm putting them on this high intensity statin, I want to have a lipid goal for them. Okay, so if the condition is that they have the primary hypercholesterolemia and their baseline was more than or equal to 190 milligrams per deciliter, my LDL goal is going to be less than 100 milligrams per deciliter. Okay, this is going to be my goal. So then I'm going to monitor them every 4 to 12 weeks, every 3 months, every 6 months, depending on what goals I have for them. So as I'm monitoring them and I find out that their LDL is actually more than or equal to 100, this is when I say, you know what, you do qualify now for an add-on therapy. So then I can add on ezetimibe or PCSK9 inhibitor. Okay. Another thing to keep in mind is that there is a PCSK9 inhibitor known as Repatha, and the generic name is evolocumab. This one, you could add that to a primary hypercholesterolemia if their baseline is more than or equal to 190, which means you don't really have to go down the route of high intensity statin. You can directly put somebody on Repatha because Repatha does qualify for putting somebody on it directly without using the statin if they have the primary hypercholesterolemia with the LDL more than or equal to 190. Okay, so that's one thing. Another thing to know is that if the patient had clinical ASCVD, when I say clinical ASCVD, I mean they've had a previous event of heart attack, stroke, something related to the cardiovascular. So they have had a cardiovascular event. Now, the question you want to ask yourself are number one, are they at a high risk? Okay. If they are a high risk patient, meaning the risk of them getting another cardiovascular event is very high because they have a lot of risk factors or other things. Or if they're, and another condition is whether they're high risk, or the second thing is if their baseline LDL is more than or equal to 190 milligrams per deciliter. In either case, whether they're high risk or their baseline LDL was more than or equal to 190, the goal LDL is going to be less than 55 milligrams per deciliter. So I'm going to monitor them closely. And as I'm monitoring them, if I find out that their LDL is actually more than or equal to 55 milligrams per deciliter, I'm going to say now they qualify for an add-on therapy, which is ezetimibe or a PCSK9 inhibitor, whatever I choose. Okay, now this clinical ASCVD patient, if they are not at a very high risk, so not very high risk patient, or the patient case might say they're at low risk, then the goal is going to change. The goal LDL for this patient is going to be less than 70. Okay, so now if I do the monitoring and if the LDL comes back to be more than or equal to 70, then I say, okay, now they qualify for an add-on. Okay, the third thing that we should remember is if the patient has diabetes, then again, the goal LDL is going to be less than 70. Or if the patient ASCVD risk is more than or equal to 20%, then again, the LDL goal is going to be less than 70. And this could be true. So if the patient has diabetes, yes, LDL has to be less than 70. Or if the patient's risk is more than or equal to 20%, then yes, the LDL goal is less than 70. But even if both of these conditions were true, the patient had both diabetes and the risk was more than or equal to 70%, then again, the goal remains the same, which is LDL less than 70. Okay, so now if the LDL comes more than or equal to 70, they will qualify for an add-on therapy, which is ezetimibe. And or not and ezetimibe or PCSK9 inhibitor after they have successfully been on a high intensity statin or maybe the maximum tolerated statin that they could take. The LDL is still not at goal,